It's my pleasure now to turn us to the first panel and to my colleague, Kosali Simon. Kosali is the Herman B. Wells Endowed Professor in Health Economics at the O'Neill School of Public and Environmental Affairs at Indiana University. Take us away, Kosali.
Thank you, Ray, and thank you, Sandy, for setting those comments that give us the background for why it's so important we address this topic. It's my pleasure now to briefly introduce our three panelists, and I'm going to refer you to the attendee packet for their complete bio sketches. In alphabetical order, our panelists are Kate Baker, who is the Dean and Emmett Dedman Professor at the Harris School of Public Policy at the University of Chicago. Monica Burrell is the Public Health Commissioner of the Commonwealth of Massachusetts. And Mac McCullough is Associate Professor at the College of Health Solutions, Arizona State University. I'm going to start with just some remarks to set the stage for this particular panel and outline the session's objectives. And please note that we will consider audience questions as time permits, but please enter your questions into the Q&A field below in the webcast window. So we know that COVID-19 has brought unprecedented pressures on healthcare spending and how we are delivering and sustaining our public health infrastructure. So as we recognize that healthcare spending is really integral in the discussion on social determinants, we start off with this fact that we are spending 1/6 of our economy in the healthcare system. But even thinking about projections that were made prior to COVID-19, our healthcare spending was projected to grow at 1.1 percentage points faster than our GDP from 2019 to 2028. So that also means that as a share of our economy, healthcare spending from 17.7% in 2018 was projected to grow to 19.7% by 2028. Healthcare spending growth, we know in 2020 went off of these projections because of the pandemic. And by some estimates, the year-over-year spending growth comparisons in the second quarter of 2020, we were down 8% in healthcare spending compared to the same time period in 2019. But by the third quarter, we were back in the positive numbers. That is, that healthcare spending was back to growing faster. We were spending more than in 2019. So there's a lot here to discuss as we consider what's in front of us. The panelists are going to now give us remarks to consider. And we're first going to have Matt McCullough speak, and then Kate Baker, followed by Monica Burrell. So I'm going to now turn it over to Matt.
Wonderful. Thank you very much, Kosali. And it's a pleasure to join today. And thanks to the Roundtable and the Planning Committee for inviting me. This is a pleasure to be here today. So without any further ado, we'll get started. And it looks like the first slide is up on the screen. And I'm sure we'll hear if it's not, but my name is Mac McCullough. I'm an associate professor at ASU and a health economist at Maricopa County Public Health Department. So I sit sort of at that intersection between academics and public health. And as anyone who sits in the government would be able to predict what my next slide will be, it is that the views expressed today are my own and don't necessarily reflect the positions of my organizations. So just as a level set, and we've already heard this from both Dr. Baxter and Dr. Magnan, so we spend a lot more on medical care than other nations do. This is a selection from one of the articles that was mentioned in that AJPH special section. Yet our life expectancy lags our OECD peers. And this is sort of true no matter how you slice it and dice it. There are ways that you can come up with other interpretations of these data, but you have to do a little bit more than just look at the overall system-wide impacts of spending and of life expectancy. So that's really where I want us to sit today and sort of sit in that uncomfortable place. And so why might this be? What is the source of the disconnect between healthcare spending and health outcomes? Two potential things that we can talk through here today is that not all drivers of health outcomes are touched by healthcare spending. So our social environment, our physical environment are not necessarily touched by the healthcare or medical care, clinical care spending that was shown on that first slide. And then not all healthcare spending impacts health outcomes. So spending that does not improve health is referred to and can be referred to as wasteful spending or non-value added spending. So that first piece, the not all drivers of health outcomes are touched by healthcare spending. Some argue that we spend close to the OECD mean for social spending, right, which is where we talked about getting in terms of our health outcome spending, or excuse me, our health care spending. I actually argue that it's worse than that though. So this includes spending on pensions and on health, right? So if we take those out, if we only look at family benefits spending, which is more sort of what we think of when we think of the core social determinants of health spending, we rank second to last. So even if best case scenario we're at the mean, that's different than where we look for our healthcare spending. I argue that we are not at the mean, that we're far below that. So okay, that's number one. We're not spending quite as much on the social underlying social determinants such as social environment, physical environment as we are on our clinical care. And the second piece, not all healthcare spending impacts health outcomes. Let's dig into what wasteful healthcare spending actually is. So when I say wasteful spending is a way of thinking about healthcare spending that does not improve health, that's not just me. That's 6 different sources over the years that have looked at a system level view of wasteful healthcare spending. So not looking at wasteful practices as it relates to billing or insurance administration, or just looking at high prices, all of which are important on their own. This is a system view. To get that one number, we have blank number of dollars or blank % of our spending is wasted. For the most part, there is some disagreement in terms of what actually gets counted as waste and how much waste is, but all of these sources shown here largely agree that wasteful spending is spending that does not actually improve one's health, and spending that could be removed from the system without having negative impacts on health. Right? So you could argue, the price that you pay for some form of insurance administration or other sort of boring bureaucratic administrative things doesn't improve your health. But if you took that away, that might actually influence health. We're not talking about things that are just kind of boring. This is things that if you took them away, health outcomes, there'd be no discernible impact there. So what constitutes wasteful healthcare spending? Over the years, again, those 6 sources that were shown on the previous slide, they sort of fell into about 6 buckets. And we had to do a little bit of work to get these buckets to coalesce. But in general, we can think of clinical inefficiencies, missed prevention opportunities, overuse of services, administrative waste, excessive prices, fraud and abuse. This is sort of an easy first level way of thinking of it. The more you sort of dive into it, the more you start to recognize interdependencies and overlap between these categories, right? Excessive prices is related to a lot of these, especially to overuse or misprevention opportunities. Fraud and abuse and overuse are sort of along this, probably on the same spectrum of things, and where you draw the line specifically between those 3 things is sort of an art. That said, the numbers on this screen are huge. So what I want us to work on today is thinking about what it means that in addition to the fact that these dollars that are spent on medical care may not have an impact on our health outcomes, they also aren't available for us to use for other things, right? So if we spend $1 on a test or a scan or something we didn't need to do, that's $1 less that an employer, say, if this is a private health insurance scenario, have available to pay employees or remain globally competitive or satisfy shareholders if it's a for-profit company. A dollar spent on prices that are too high is, give or take, a dollar less that the federal government would have to reduce debt or to do other public priorities. And a dollar on administrative overhead is a dollar less that can be allocated towards social or infrastructure priorities that do improve health outcomes. And this third piece is especially relevant for us today because, as we will see, we have opportunity in this area that is, I think, currently unmet. So what do we mean by this opportunity cost? This is the formal definition that comes from the New American Oxford Dictionary. The loss of potential gain from other alternatives when one alternative is chosen. So if we buy a $7 strawberry smoothie today, that means we can't buy a $7 kiwi smoothie, or a movie ticket, or gas, or flowers, or whatever. It also means that we don't have the opportunity to invest or save that money and buy other things later, maybe things that cost more than $7. So there is an opportunity cost for us choosing to allocate and living in the system that we live in. So again, the opportunity cost of our medical care spending, which is the highest in the world, as we saw, as we've seen a couple times already today, the opportunity cost of $1 spent on medical health-seeking strategies is a dollar less that is available to be spent on other priorities. So non-medical health-seeking strategies, non-health priorities, or profit, rent, wages, whatever we want to call it. I would argue that the opportunity cost of medical care spending may be logical when medical care spending improves our health. So that becomes sort of a normative decision, right? Does the medical care benefits that I got from that medical care spending that improved my health, is that better or worse than that strawberry smoothie that we didn't buy, or that trip that we didn't save up to take? But what happens? How can we consider the opportunity cost of medical care spending if that medical care spending doesn't improve our health? I think that's a really interesting area, and it's an important area for us given the size of the categories that we saw in terms of the issue here, the size of the waste. So $1 wasted on medical care, just a couple caveats here, represents waste to the individual or entities that are paying for that care, right? They're paying, or he or she, someone is paying, something is paying, and not getting any health benefit from this health spending. But there's some potential theoretical value to the patient, right? If it's just really reassuring to get that out-of-network lab work done instead of an in-network lab done, to get that anesthesiologist that comes in and you talk to them for 2 minutes, and you pay 10 times as much. There may be some theoretical value there. So we should probably consider that at some point. And there's also the fact that the really sticky and important fact that a dollar, in quotes, wasted on medical care represents or can represent revenue to others. Right? So if we do two tests instead of one test, there's no medical benefit to that second test, but there is a payment that is received by somebody for that second test. And that is a really, really challenging portion of this whole thing. All right, so when we have one alternative, which is we currently spend, as we saw a couple slides ago, $879 billion. That's not my estimate, that's the median estimate of the literature that's been published on this topic for the last 10 years. What are all our alternatives there? What else could we do with $879 billion? And this is, I think, the part of this conversation that we sometimes don't spend enough time in, which is there's some sort of maybe coalescing agreement around the fact that there's waste in healthcare, that we spend a little bit too much in healthcare, and that there's other things that drive health outcomes. The reason that I'm sticking on this point right now is the size of this is so huge that it's almost impossible to overstate. And it's like, if our car kept breaking down every month, we wouldn't just keep throwing checks at the repair shop saying, oh yeah, it's broken, that's fine. Oh yeah, it's broken, that's fine. We would pause, right? What is the underlying issue here? And what else could I be doing, right? Could I just fix the underlying issue rather than spending, however much I need to repair my car every year? There's an essentially unlimited combination of things that we could do with this amount of money. So I'm not here to say that there's one right path and every other path is wrong. There are some that are pretty fun to consider and may benefit society. So we could repeal the estate tax. That would save us 64 billion, or we'd have to refund that somehow. With this savings, we could switch to renewable energy. That's really fun to consider and may in fact benefit society. But there's also some that may improve health. Right? We could reallocate that towards medical tests, medical procedures, coverage that do impact health outcomes. So we could reallocate the 879 billion of non-value-added healthcare spending to value-added healthcare spending. We could actually also look at non-medical programs that aren't currently implemented that do impact health outcomes. So thinking about social, quality of life, housing infrastructure, climate, really a host of things. And I'm going to spend a little bit of time digging into this section here because I think that it's important for us to really think about how we can drive health with spending on health versus spending only on one portion of things that drive health. So, all right, if we have $879 billion per year in wasteful healthcare spending with no impacts that could be taken away without negatively impacting health outcomes, that's a little bit over $2,600 per capita. $2,600 for every man, woman, and child in this country. Some of that we can say, arises out of the private sector, and some would arise out of the public sector. If we just use the overall ratios of healthcare spending for this country, roughly 55 and 45, I'd be happy to adjust those. If you really don't like 55 and you think it's 60 or 50, that's fine. I'm not going to talk about the private sector here. We'll leave that aside. So whatever that company decides to do with its $1,457 per capita, that's fine. If you want to, build another factory or have Friday happy hours, whatever you want to do. We're talking about the public share, which I think is sort of up for debate and up for discussion. But what I'd like to do is leave about half of it for deficit reduction or for other priorities. Right, so if you really, really, really are worried about the size of the deficit or other things that the government is or isn't doing, we still have $198 billion a year for that. I'm setting that roughly $600 per capita aside. And I'm only going to be talking today about this last piece here, this $198 billion. And we're going to look at some things that the alternative uses for $198 billion if our goal is to improve health outcomes. So, and just as a note here, as I go through these next couple slides, this bar at the top, this is to scale. If this bar is $879 billion, I'm only talking about this shaded portion. Right, so there's a whole lot of other wiggle room that we have here. So what could we do if we wanted to look at socially focused programs that have a health outcome? So we could spend about $3 billion or $3.3 billion to give nurse home visits to pregnant smokers and pregnant teenagers. This nurse home visiting program has been causally linked with the reduction in the incidence of ED visits over the first 2 years of life and in the incidence of low birth weight. All right, so there is a dividend to that spending insofar as there's reduced morbidity, reduced, in theory, mortality, but there's an improvement in health outcomes. And again, this causal evidence is not mine. It is cited from a study that I and a few colleagues did about a decade ago now or so. And so I very much appreciate the contributions and partnership from Professor Fred Zimmerman from UCLA, Professor Jonathan Fielding from Los Angeles, UCLA and LA County, and Dr. Stephen Teutsch. I'm not sure if any of those are in the audience today. If they are, hello. We also have about $9 billion that we could use to put students in elementary school into an evidence-based social development program with causal linkages with decreases in risky sexual behavior and drug use, improved work, social, and emotional functioning as adults. Expand Head Start to serve all eligible children. We only serve about half. There's some mixed evidence on the long-term effects of health of Head Start, but there's some pretty decent evidence on the short and intermediate term outcomes. We could provide universal pre-K to non-Head Start participants. We could reduce class size. All of these things fall into this bucket of about $120 billion per year that we could spend on socially focused programs that are causally linked with improved health outcomes. None of this can be done currently without expanding the amount that we spend, unless we start to take a look at what we spend on medical care that does not improve our health outcomes. So quality of life programs, I'll just sort of quickly go through this. 58 million for investment of greening of our built environment, community facility and rural economic development grant to every small town in America over 10 years, safe routes to school for every school in America over 10 years, double the size of our Job Corps program, universal basic income for individuals from low-income neighborhoods. There's just some interesting data that came out of Stockton, California in the last several months that did a randomized trial of providing about $500 per person or per household per month to individuals from low-income neighborhoods. And it was associated with a host of significant impacts relative to a comparison or control group. We could expand public libraries for every library in the US over 10 years, double our investment in water infrastructure, expand SNAP to cover all food insecure individuals. All of these things could be done with still under this small sort of sub portion of that health dividend. Housing has become an incredibly important and increasingly studied aspect of this issue. We could probably pick other interventions here, but this is just an intervention where you provide housing to chronically homeless individuals with severe alcohol problems, really high quality studies that have been done that show that this is causally linked with improved health outcomes, and actually it's cost saving. So there's this like second level piece here, right? So one of the outcomes I talked about was a reduction in ED visits, right? So that actually further reduces our healthcare spending with, in theory, no further needs or costs. We could fulfill our public transit backlog over 10 years. And we could also adopt a disaster mitigation and adaptation fund that was identified by the GAO. This actually comes from Canada. So all of these things could be done, right? If you don't like some of those, or you have your own priority programs that you're more focused on or you're more well versed in, fantastic, let's do it, right? Behavioral crisis intervention teams, that's $3 billion. Full funding of our nation's public health system, as we've heard about, we need one of those. That's on the order of $4 to $8 billion. That's chump change compared to $879 billion. We have equity initiatives. We have Seed for Oklahoma's Children, social impact bonds. We could address Medicare insolvency with some of that, that debt reduction piece or this health dividend piece. We can really do a whole lot of things. So remember, the priorities that I've talked through represent only the shaded portion of the orange box above. The rest of that $879 billion pie is retained for other public fiscal priorities or by the private sector. And an overriding principle of this sort of health dividend concept is that there is an opportunity cost to our prioritization of non-value added medical care spending over evidence-based programs outside of the traditional medical care sector. And that reprioritizing an evidence-based social and quality of life, housing, infrastructure, climate programs may yield a health dividend above and beyond the health outcomes that are generated by our current healthcare spending portfolio. So that it became too unwieldy to actually calculate out, gains in life years if we do some of these programs. But the theory here is there's causal evidence that this program, spending on this program improves health outcomes. And by definition, the spending that we're looking at, the healthcare spending we're looking at does not improve healthcare outcomes, or at least it could be taken away without harming health outcomes. So to consider, I mentioned a few slides ago that the US has the second lowest family benefits spending of any OECD nation. Is this because we can't afford to, or we don't want to afford to spend more? I don't know the answer to that. But the reason that I did the way that the shaded bar at the top looks the way that it does is that I think there may be some of that second bullet, or excuse me, the third bullet there. We don't want to afford to spend more. Right, so even if we don't want to afford to spend more, we can do a whole heck of a lot with the lighter shaded portion of that bar and reap rewards from the darker shaded portion of the bar on the left. The net budgetary effect of the initiatives here would reduce spending on health and well-being with a positive health effect. So great, that sounds nice, and I'm guessing there's a lot of people who are like uncomfortably sitting and twisting and turning in the chairs, thinking, cool, you've said nothing controversial except how do we actually do this? What I will say is it's a big to-do, it's a big ask. We have, luckily, everybody else that follows me in the program can do all of that. But I'm presenting this here for a couple of reasons. One is I don't want us to just launch right past the fact that we have this huge amount of healthcare spending that doesn't improve health. And we have this huge deficit in things that do improve health. I think it's important for us to stew in that for a little bit, because actually getting to reducing that wasteful spending is really hard, and you start to bump up against entrenched interests and sort of political interest, politics for that matter. But I don't want us to just hold off and do nothing, because as we've seen, even when things change a lot, right, so this is healthcare spending year-over-year growth at a quarterly basis. We can probably all pick out the quarter when COVID happened, right? How do we know that COVID won't just sort of take care of this, and we'll see a new normal that emerges from this? So we saw a roughly 8 or 9% reduction in medical care spending during last year in one of the first quarters. We would need to see a 7% reduction in spending, in healthcare spending, in order for us to reach the OECD median over the next decade or so. We'd have to essentially have more or less the same exact thing that happened during the COVID quarter happen every single quarter for the next decade to get there. We are a long ways away, and the scale of this issue is paradoxically both a challenge and an opportunity. I know 879 billion sounds like a lot, but in reality, it's almost unfathomably large. Sometime when you have a little bit of spare time, go look at some of the things that, like how big a billion is. The human brain almost cannot comprehend how big a billion is. It's unfathomably huge. And it's kind of fun to think about all the things that you can get out of 879 billion. So when it's that, it almost loses, like we lose sight of the ground from that level. And so it's it's really unfortunate, because I would bet that almost every single person here has been directly impacted by this issue at some point probably in the recent past. I have it several times this past year alone. And to sort of take that away from it, to take that surprise bill away from that feeling you got when you open that envelope and just say it's 879 billion, it like really removes us from it, right? It depersonalizes things a lot. So what I hope that we can do here is really stew in the fact that we have this opportunity that arises from this opportunity cost. And we also have probably more, right? I've only talked about the zero value add cost. What about low value care? What about high overall levels of spending? Where we have further opportunity here that may be able to drive even additional considerations here. And so as we think about moving forward with this, I want us to recognize the opportunity cost of our high levels of healthcare spending, and consider how we are allocating our resources to the point where some people don't have access to the system, period, and others have so much access that we're spending above and beyond where we actually get any medical care benefit from our medical care spending. So I will leave it there and turn it over to the rest of the panel. And I appreciate the opportunity to talk and to sort of share this thinking. And I welcome discussion, comments, and feedback.
Thank you so much, Mac. That was a really, really fabulous way you have helped us understand what the literature has, what the research shows about how much medical spending could be considered wasteful, the ways to think about it, and this opportunity, the the scale, as you said, is just unfathomable when we go into numbers this large. It gives us so many opportunities to think of socially focused programs that could happen with all of that money. So I'm going to now turn it to Kate and ask, why is this such a challenging problem for the nation to grapple with this high healthcare spending and to try and do something about this amount of money that's waste?
Thank you so much. I'm delighted to have a chance to be on this panel, and I'll speak very briefly because I know we want to leave plenty of time for Q&A. So I just want to make a couple of points. I think we have two goals. One is to expand access to care for populations that have way too little access and are suffering dramatically, not just under COVID, but under the incidence of non-communicable diseases, limited access to mental health services, to substance abuse, to management of diabetes and cancer and high blood pressure. So we need a system to address all of that. But expanding access to care does not save money. I think we would love to think that if we got people access to primary care and preventive care, that would keep them out of expensive hospitalizations and out of the emergency department, and we would actually save money. I think the literature suggests that when you expand access to care, people get much needed care that is a major improvement in their health, in their financial stability, and more, but it costs money because they're using more care. And so we need to think about how to expand that access sustainably by cutting back on low value care or wasted care. So I think that that's exactly the right set of questions to ask, is how do we make sure that every healthcare dollar we spend is going to something that produces a substantial amount of health. And to me, it's not obvious that we're then going to spend less on healthcare. We might spend more if we were spending on things that we have been underfunding before and generating a lot of health. That would be a great thing. I don't have a strong view about whether we should spend 10% of GDP on healthcare, 15%, 25%. If we were living to age 100 or 200, that'd be great. That would be money well spent. But I think the evidence Mac and others have produced shows us that we're not getting that value from our healthcare system, that it's the opportunity cost we need to focus on of driving higher value use of every dollar, whether it's on healthcare or somewhere else. The challenge is that healthcare doesn't come with a label that says this care is wasted and this care is of high value. All of the estimates that are produced of wasteful use in the system, there's a huge range of those estimates. It's hard to pin down, but it's very hard to say this specific MRI was wasted, but this MRI detected something that was really important that we could treat. You can't say MRIs are bad or MRIs are good. Some are really valuable, some are wasteful, and everything in between. So the challenge is how you set up a system that reduces the use of low value care, but maintains access to high value care and maybe even drives innovation so we get the next vaccine or the next treatment to benefit as many people as possible. I'm really glad that Mac returned to the end at the question of low value care. We are all against waste, fraud, and abuse. We definitely want to eliminate care that produces zero health. I think there's a much, much bigger bucket of care that produces some health, a little bit of health, but costs a lot. And so how do we make sure that we don't spend too much on that care that is of low value, but not sufficient value relative to the opportunity cost? Who's going to make that decision? Who's going to write down the set of rules to say these things are covered by our public programs and these things aren't? That's where the rub is. And so setting up a system with incentives on the provider side, I think even more importantly than on the patient side, but you want them both working in the same direction, to encourage the use of high value care and to expand access to high value care for populations who don't have sufficient access, while limiting incentives for low value care. Take something like a statin for diabetes. For patients with diabetes, a statin to lower cholesterol is incredibly cost effective. We want to have no copay for that. Maybe we even want to pay diabetic patients to take statins. Whereas the same statin for somebody without other risk factors, might just elevated cholesterol, but no other risk of adverse cardiovascular events, that might be really wasteful. That might not be a good use of those resources. Maybe you want a copay that depends on people's income, but is something more like $50 or $100. We need more sophisticated insurance design so that what patients pay lines up both with their resources and with the value that the care produces. And I think even more importantly, on the provider side, we need to be paying for value and outcomes rather than volume and quantity delivered. It is also important when we talk about prices to remember that price and quantity are not independent levers that we can pull in the healthcare system. What we spend on healthcare is price times quantity. And if you survey people, they all say, yes, I would like my healthcare to cost less. I want the prices to be lower. But if you had a policy that said prices for healthcare are hereby cut in half, you would have severe restrictions in access. You'd have quantity drop as well. So you have to think about those two levers working together and decide, do we want to drive more access and more use, or less access and less use? And for some things, we're probably using too little healthcare. We've talked about, missed prevention opportunities. I don't think there are so many of those opportunities that actually save money, but I think there are a lot that improve health. We want to drive higher use of those underused services and lower use of the overused services. So I think we're going to have a much more nuanced set of insurance policies for individuals and payment policies for providers. The last point that I will leave you with is thinking about these non-health care inputs into health. And this is a really important area of emphasis. Lots of things affect health outcomes besides healthcare, and that is, the focus of a lot of what you're going to hear about over the next couple of days. It is, I think, tempting to think that we should cover all of those things with our healthcare programs so that we will get better health outcomes, and it'll be better to spend money on food for patients whose diet is adversely affecting the management of their disease, or air conditioners for kids with asthma who end up in the emergency department. And those are great things to spend money on that improve health. The challenge is, how do you target them? If you use your health care or health insurance program dollars to cover food, you're going to buy a lot of food for a lot of people that's not necessarily going to improve health commensurately. It'll keep people from being hungry. So if you want it to be a food program, that's a wonderful use of resources. But I think if the goal is to improve health outcomes, one has to think very carefully about how to target health program resources and resources outside the healthcare system that also affect health. And one of the novel mechanisms for doing something like that is a pay-for-success contract, or a way to add flexibility to programs coupled with accountability. You might think that delivering nurse home visiting services, for example, would improve health outcomes for new mothers and their children, and that something like that should be covered through Medicaid. I'm part of an evaluation of just such a pay-for-success program in South Carolina. The question is, does that achieve the health outcomes that the Medicaid program is aiming to improve? And we're doing a randomized controlled trial to see what the outcome is. I think coupling that kind of accountability with the flexibility to spend health dollars outside the healthcare system could be a way to drive much higher value use of our resources and better health outcomes. So I will stop there and turn the microphone back to Kosali.
Thank you, Kate. I think you've really illustrated the tension well that exists between expanding access and trying to address what we know are huge inequities in access, while at the same time keeping the cost down. And now you're bringing this importance of trying to figure out where the opportunities are in the high value kinds of cases, and how it is we can be trying to shift from volume to value. Lots of things that are coming up, and many things I'm seeing as questions I'm going to line up soon on follow-ups. But I want to turn to Commissioner Barrow and ask, you've been spending a lot of energy in Massachusetts shifting the focus to advancing health equity and figuring out how to shift upstream these investments. What is it a state can do in this setting?
Thank you so much. And I'm really excited to be part of this panel and really appreciate the invitation. And we'll specifically be addressing some of the really important questions that the two speakers before me raised. You know, number one, how do we do this? And number two, how do we think about shifting dollars with accountability from healthcare into health? So let me first say again to emphasize, I know we can't say this enough, in the United States, we spend too much on healthcare costs without good and equitable health outcomes to match our investments. And again, as my fellow panelists have said, you know, if we were spending all this money and getting superb health outcomes, we would be having a different discussion, but that is not the case. And as mentioned, much of this is related to waste in our system. I'm a primary care internal medicine physician, and I've spent over 20 years doing clinical care, always in resource limited settings, where this kind of waste is particularly hard to see as the needs are so high. Getting back to that comment of there are a lot of needs for healthcare access for high value healthcare. I've witnessed so many examples of unnecessary waste in our healthcare system firsthand. I was with Boston Healthcare for the Homeless program for 12 years. And I remember asking one particular patient if he had contacted his case manager to help with his housing search. Housing being a key social determinant of health has come up in Mac's presentation as well. The patient asked me which case manager, as he was assigned 5 to 6 different case managers from different programs, and none were truly helping him. I've seen countless instances of us discharging a patient after a long and very expensive ICU stay for addiction-related medical complications with a phone number in hand, as opposed to a warm handoff to a community provider. No one would be surprised when this patient is readmitted days later. These and other examples of waste are avoidable, as we've heard discussed already, if we focus on health in addition to healthcare. So these experiences that I've had in my own personal journey have driven me to want to contribute to changing the system, right, with a focus on upstream community engagement and policy change. And this is really about focusing on overall health beyond treating just the disease for which the patient presents. So there's lots of ways we talk about upstream, right? There's our individual interaction with a patient who's presenting with a disease and a complaint, and we're interacting with that person. Going upstream from that, some people talk about population health, but I postulate some of that work that we see is really population medicine, where, for example, my health system might be looking at all of our patients with asthma and how do we bring those patients in, but again, to think about their disease. And what I really would hope that we can all talk about when we talk about population health is going further up to that, to these structural and institutional policies and biases that really drive how much health opportunity each of us has. And I'll talk about that a little bit more. I came to the Massachusetts Department of Public Health in 2015, where health equity is embedded in our mission. And many health departments are really in their mission focused on these concepts of health equity and opportunities and choice in health for all of us. At the Massachusetts Department of Public Health, we opened a new Office of Population Health to really focus on using our abundant amount of Department of Public Health data to better understand the social determinants of health and the data disparities, which then lead us to the communities and populations where we need to focus our attention and resources. We've pursued this precision public health model, if you will, over the last 6 years. One outcome is that in Massachusetts, at the Department of Public Health, we've flipped our model from looking at specific conditions or diseases, such as substance use disorder, heart disease, or diabetes, instead to look at populations who are most burdened by these illnesses. No matter what condition you look at, it's unfortunately the same populations carrying excess burden of disease. These populations, often due to social and environmental burdens, include, from our data, communities of color, individuals with a history of incarceration or homelessness, individuals with a history of substance use disorder or mental illness, and pregnant and postpartum women, including, by the way, issues related to maternal morbidity or mortality and infant mortality rates, which were mentioned earlier. This approach has also served us as we look at all of our work through a racial equity lens. This last year has heightened the general public's awareness as we saw the devastating and disproportionate impact of COVID-19, emphasizing that we together have much work to do still. So I'd like to now share 3 brief examples of how at a state level we are moving upstream to give you some concrete examples of how we're addressing healthcare in the context, moving upstream of healthcare to address overall health and health equity. And again, it relates to some of the prior discussion of taking funding from the healthcare system and using it to really advance health overall. The first program I'd like to talk to you about, this initiative is called MassUp, or Moving Massachusetts Upstream Investment Program. The MassUp investment program is aimed at supporting partnerships between healthcare providers and community organizations to enable sustainable improvements in community health and health equity by, again, moving upstream to address the social determinants of health. The current focus of this program is on food systems and security and economic stability and mobility. The vision of Mass Health, which by the way is an interagency initiative, is many of the things we're talking about today: better health, lower costs, and reduce health inequities in Massachusetts through effective collaboration among government, healthcare systems, and community organizations. Just to give you a flavor, the state agencies involved in this collaborative are my agency, the Massachusetts Department of Public Health, the Massachusetts Executive Office of Elder Affairs, the Office of the Attorney General, the Executive Office of Health and Human Services, and our Health Policy Commission, which in Massachusetts was set up in 2012 to monitor healthcare spending growth. The MassUp investment program is part of our Department of Public Health's ongoing work to achieve health equity by supporting grassroots community innovations that can lead to lasting change, which is what we're here to talk about today. 4 communities have been awarded grants through state funding. As an example, just to give you an example of one of them, one community is working on food security, and the group includes critically the local medical center, as well as community-based organizations such as the Food Pantry and the Food Security Council. They're working with food retailers and residents to expand locations of affordable, healthy food, and increasing community engagement to increase access to existing food benefits and entitlements, which you heard a little bit about earlier. The second initiative that I'd like to talk to you about is our Community Health Investment Program. Now, as I've said, our goal in Massachusetts is to take a data-driven approach with a focus on quality public health and healthcare services and an emphasis on social determinants of health, with our goal to be eradication of health inequities. So we all recognize that health inequities result, as we've said, not just from individual behaviors, but largely from the conditions in which people are born, grow, live, work, and age. We work in this program to address not just the healthy behaviors, but also address the systems in our communities that determine health. And this is what I was talking about moving upstream to the systems. And one of the systems within our bigger ecosystem is our healthcare system. Now, in Massachusetts, we have a determination of need regulation. Often it's called certification of need in other states. And it's one tool that we have to require and encourage healthcare systems to move upstream. So in Massachusetts, health systems who wish to do any renovation or expansion must apply for this determination of need project. And again, in Massachusetts, 5% of the project's capital expenditure must be invested in community investment projects. So in 2017, we updated our regulations to require those investments. Remember, these are investments that are already required to go to the community, but we required them to have increased accountability and to directly connect to our state priorities that were data-driven to engage the community in planning and address upstream health issues. So these health priorities were set as including addressing homelessness and housing instability, substance use disorder, mental health and wellness, and preventable chronic disease. Importantly, we encouraged hospitals to be explicit concerning the role of structural racism in creating inequitable community conditions. When hospitals provide our Department of Public Health details on the strategies they intend to implement, they're required to answer questions. I'm going to just give you some examples of those questions. So this is, again, getting to the accountability issue we spoke about earlier. What is the inequality of interest? Where or what is the injustice the system is trying to solve? Does this proposed strategy address racial or other inequities by helping to dismantle structural racism or other structural causes of inequality? What might be the unintended, positive or negative, outcomes of this proposal for people of color or other populations? And what are you doing to ensure negative outcomes are addressed? So just to give you some examples of that new regulation, it's been really impactful with our hospital partners. Again, this was money already going into the community, and we've seen investments for the first time in things such as housing and addressing food deserts with grocery store investments and other examples, really addressing the health of the populations they serve beyond their healthcare needs. The third and final example, I can't stop without talking about COVID and the community inequities we've seen related to that. I want to first join others who have acknowledged the tremendous loss of life and suffering that this pandemic has caused in my state of Massachusetts, across the country, and around the world. In Massachusetts, the three pillars of our pandemic response have been: number one, preserve life; number two, preserve our healthcare system; and number three, equity, reaching our hardest hit populations. So equity is at the core of our COVID-19 response. And early in April, we began to acquire demographic data, including race and ethnicity, for COVID-19 cases, which has helped us document and therefore address some of these inequities. We established a COVID-19 Health Equity Advisory Group in May 2020 that assists us in looking at data and understanding and responding to the social determinants of health that have led to this unequal COVID-19 burden in some of our communities and members of our Commonwealth more than others. I want to speak for a minute about some of these interventions because I think they directly tie to what we're talking about here. And it's really about taking the data that we have, and we've reviewed a lot of data, and combining it with the community narrative and the voice, so that in all of these things that we're talking about over the next 2 days, we're really thinking about what each individual community needs. So in the fall of 2020, we deployed a statewide community survey to better understand the immediate and long-term health impacts of the pandemic, ranging from things such as access to testing and delays in healthcare, but also to things such as access to housing, food, safe working conditions, and other factors that we know are contributing to our COVID-19 burden. We engaged a network of community partners to intentionally reach minimum numbers of respondents who oftentimes don't respond to surveys, but were highly impacted communities related to COVID-19. And this included, but was not limited to, LGBTQ plus residents, residents with disabilities, residents with homelessness or housing instability, and residents of color. We had over 33,000 people respond, really allowing us to better understand the unique needs and experiences of these priority groups. From the initial analysis, we already see that many of the groups disproportionately affected by the virus itself also face disproportionate consequences of the pandemic in other aspects of their life. The groups experiencing greatest inequities across all topics included many of those groups that I mentioned: communities of color, people with disability, individuals with low income and educational attainment, the LGBTQ community, and those who speak languages other than English. And we're using those survey results to prioritize resource deployment and address inequities created and exacerbated by the pandemic. And as you can see, related to what my other panelists spoke about, it is about access to healthcare that's high value in some instances, but also addressing these other issues of health that are directly impacting risk for COVID-19. And finally, I'm pleased to say that we've just launched a new health equity initiative in line with our data-driven DPH approach to precision public health. This initiative is focused on our 20 hardest hit communities in our state from COVID-19, and it includes enhanced assistance, support, and resources with the goal of increasing access to vaccine for these populations and building trust and confidence in vaccine. The way that we targeted outreach to these 20 cities and towns was we looked at the greatest COVID-19 case burden, but also the social determinants of health, specifically using the CDC's SVI index, and looking at communities who are disproportionately impacted, communities of color. So this approach acknowledges and begins to address both historical trauma and continued distrust of communities marginalized in our society, and access needs as well for unmet needs. This initiative brings resources to these communities and supports them, again, based on these two principles I've been speaking of, using data to inform evidence-based resource allocation and including the narrative from the community. So we're engaging those who we're trying to reach, asking them what they need without assuming we have all of the answers. And I hope that we can keep that in mind as we continue to talk about these issues, which many of us have been working on for a long time. I'll just end my comments by saying I want to emphasize using the data and focusing on data disparities. And when we see that certain populations we know are overrepresented when it comes to burden of illness and disease in multiple different categories. And as we think about the way we address these issues, I urge us to think about the way that things are paid for. So the bucket of healthcare costs, it's not easy, as my other panelists have said, to shift those, but these are some examples of the way to do that. Additionally, the way we think about grant funding and the way we fund innovation is really based on diseases where we know that the disproportionate impact of these diseases related to the social determinants is a specific amount of people and communities that are involved. And to address healthcare costs and waste, we need to truly take a population health approach, broadening our definition of health beyond healthcare. I've worked in both healthcare and public health, and I think there's a false dichotomy between separating the two out, and really using the power of data and the voice of our community members to create real and lasting change. COVID-19 has reminded us that the time is now to make these important policy changes and continue the important work of health equity and specifically racial equity. And it's also reminded us that we're all interconnected across the globe. And if we work on health equity, it improves health for all of us. Thank you very much. I'll turn it back over.
Thank you very much, Commissioner. You've outlined a really bold agenda that a state can take, and I love how you've brought your firsthand experiences you've seen as a care provider to the task in front of you as the Public Health Commissioner in designing such an array of initiatives. I love hearing about how data has been so instrumental in informing and all of the pillars of COVID responses that have a focus that's on equity. There's a lot that all three panelists have now helped us understand better. And I thank you also to the audience questions that have been coming. It's a really active Q&A. So I'm going to try and take on some of the questions that are coming in and draw some synthesis between some of them. And I can see a set of questions are about policies. And specifically, one is about the Affordable Care Act, and the context of the Affordable Care Act for this conversation is definitely very relevant because we know that among the aims of the Affordable Care Act are expanding coverage while improving quality and reducing costs at the same time. So I think I'm going to, any panelist, please feel free to jump in, but I'm wondering, Kate, if you might take this question on, particularly so thinking about the ACA, the Affordable Care Act as the big picture setting, but also a specific comment that came in on the Q&A is about how the Rescue Act itself, if you can comment on what are the aspects we're seeing in it. So if we think about the Rescue Act as a sign of where might the changes to the Affordable Care Act in the future be going, what are the things we might see in this administration? How much should we read into what's in the Rescue Act for the Affordable Care Act as a signal of, to what extent is it addressing the things that are in this discussion? So I'm sorry, that's a long question, but Kate, basically ACA in general and Relief Rescue Act as a specific case of how policy builds in here.
One of the key accomplishments of the ACA or Obamacare was expanding access to care by expanding insurance coverage. And there were a couple of different mechanisms. There was the expansion of Medicaid in the states that chose to expand, originally envisioned as being all states, but then the Supreme Court ruled that states had a choice about that, and many chose to expand and some did not. The second avenue of expansion was the creation of the marketplaces or health insurance exchanges, and some states run their own and some states rely on the federal plan. And there were some ancillary provisions like allowing kids up to age 26 to stay on their parents' plans, et cetera. We've spent a lot of public discourse attention on the health insurance exchanges and what the premiums are on those, and they've been somewhat volatile and sometimes higher than expected. But more people who got insurance through the ACA got it through Medicaid expansion. And that was a really important avenue for expanding access to care. What the pandemic has laid bare is one of the many costs of our patchwork system is lack of continuity of insurance coverage and access to care. Most people who get private health insurance get it through their employer. So having the twin incidence of a public health crisis and a recession means that people who got their insurance through their jobs were at risk of losing their insurance in the middle of a public health crisis. And that prompted some states to open new enrollment periods in their state-run health insurance exchanges. One of the early acts of the Biden administration was to open a special enrollment period in the federally run health insurance exchange. And what we're seeing in the Recovery Act is further inducement for states to expand Medicaid, who had not yet chosen to do so, and more subsidies for people to get health insurance through the health insurance exchanges. Those who took up those policies on the health insurance exchanges over the last years were primarily people who were heavily or fully subsidized. But there were lots of people who fell through the cracks, either because they lived in states that hadn't expanded Medicaid or because their incomes were a little too high to receive subsidies, but a little too low to be able to afford the plans that were offered. So I think those mechanisms are going to be really important for expanding coverage, and continuity of coverage is really important for managing all of those chronic physical health conditions like diabetes, like high blood pressure, that of course we need people to get access to pandemic care. We need people to get diagnosed early, treated early. We need everybody to get vaccinated, and there are huge inequities in access to that. But people are still getting cancer, and people still have diabetes, and people are still having babies. So that insurance safety net, I think, is a really important component. One other thing that I'll mention, and then I will stop because I know others probably have responses as well, is that we saw the seeds of payment reforms through the ACA, often implemented through CMMI, applying to Medicare and Medicaid, but Medicare in particular, moving towards bundled payments or capitated payments, thinking about paying for the health outcome that you want, rather than each individual input into that outcome. We also saw accountable care organizations where primary care physicians are supposed to help steer their patients towards high value care and then share in the risk and the savings associated with that. I think those are really promising levers, but they were deployed at a pretty small scale up until now. And so if you want system level change, you need to have a sufficient share of care fall into those alternative payment models for physicians, hospitals, the healthcare system to change delivery modes and to move towards a system that does better in managing care, from primary care to hospitalization to post-acute care to all of the care that people need at home. I would love to see those levers dialed up, and I think that we've seen some interest in that from the administration.
Thank you. And I'm going to take advantage. There's a question from in the Q&A that I think is going to push a little bit further on this. So Kate, I wonder if I could ask this additional question. When we look at the Affordable Care Act changes that are in the Rescue Act, do you see this as well, clearly what was needed, as you were mentioning about the continuity of care? The most important part of the Affordable Care Act right now is the access health insurance aspects. And so that's why what we're seeing in the Rescue Act are the subsidies for the health insurance, rather than the fact that there aren't aspects that are pushing on the incentives to providers for targeting towards high value care, simply because of the time period we're in. And it doesn't mean that we are done with the Affordable Care Act in thinking about how to use that structure to push on, as you were talking about, the need for value-based care.
Yeah, I think one has to start somewhere, and having a more robust safety net so that everyone has access to insurance and the care that generates, that seems like a really important place to start. It's not the end. As I highlighted in my remarks, I don't think expanding coverage saves money. I think expanding coverage costs money, and it's money well spent. In the same way that people think about, food stamps, expanding access to food stamps doesn't save money. It gives hungry people food, and that's a good in and of itself. So I think this seems like a great starting point, and there's some low-hanging fruit in the sense of gaps to be filled. There are some glitches in the original legislation that I think were not intended, based on whether affordability is defined at the individual or the family level, or people who fall into the gap in states that didn't expand Medicaid, where the law envisioned Medicaid running right up until the eligibility limit for health insurance exchanges, but in states that didn't expand, there's a gap. I think starting with those is a set of good incremental steps, but then we need to do more on our public insurance payment, particularly Medicare. Medicare is, one of the biggest single bucket of payer and drives a lot of healthcare utilization. And the effects of moving towards higher value care in Medicare, I think, are felt system-wide. A lot of private insurers piggyback their coverage requirements on Medicare. A lot of payments through private systems explicitly reference or implicitly reference the Medicare pricing. So whatever we can do to move Medicare towards paying for value and better outcomes, I think will have outsized system level effects. We think of those as incremental rather than whole system giant reforms, but I think that we can make a lot of progress with those incremental reforms, and I would hate for them to fall by the wayside because they don't seem sweeping enough. There's a lot of good that they can do.
Thank you. And I thank the audience members who are asking these questions about the Affordable Care Act, because I think it is so important for this topic. I want to see if the other panelists might have anything to add on this.
I just want to add to Catherine's comments, that it really highlights that this is a complex system that we're dealing with, and we're not trying to just solve one problem, right? So there's multiple different problems. So the Affordable Care Act and access to healthcare is so critical, right? So everybody has to have some basic access to healthcare. But to Catherine's earlier points, and I really appreciated how you phrased it, we need access to high value care. Right? So it's not just access to all care, but in addition to that, we need to do all these other things that we've all been talking about. Think about how we move the wasteful, low value or no value care to other aspects of health, and really to broaden our entire system's approach to thinking about, again, there's this dichotomy between public health or population health and individual health care. And it's all a spectrum and really pushing us to think about the whole unit. So it's not just about my patient who had congestive heart failure and do they have insurance and do they have access to a provider, and are they getting the educational program that they need? But, is the person homeless? So therefore, when you give them a diuretic, there's no place to urinate during the day, so she's not going to take it, right? So it's all connected. So, I think I'd emphasize that too, that it's addressing one piece of this problem that we're talking about today.
Thank you. We have another set of questions that are on the theme of getting the politics aligned with addressing, Mac, what you brought up as there's this huge sum of money. We have evidence on other things that might be more beneficial for advancing health than spending it all within healthcare. But how do we get the entrenched interests or how do we get the conversation shifted? It's not, you did make clear that it's not simply that you are pitching this as here are these dollars and we should just take them from one bucket to another, but that process of doing that transformation in itself is really complicated. What are your thoughts about how that process happens? What can we do to inform that debate better, and the role of entrenched interests?
Yeah, I think it's a really, really, really important question and sort of gets at the crux of hopefully why we're here today and tomorrow. But I would start with one sort of framing the discussion, which is when we think about the size of this problem, it's too big to not do anything about it. There's so much opportunity there that even if we can hit a rounding error of this, we don't have to get all 879 billion. If we get literally a rounding error on that, we could fund our public health system, period. Right? We could fund whatever housing or quality of life or infrastructure, whatever our priorities are, we can do it. So what I would suggest is, one is we don't just like sort of brush that aside. That's really important to keep in mind, that the payoff for this is huge, the opportunity cost is huge. With that said, what I would probably start with is sort of a top-down and a bottom-up approach at the same time. There's some really interesting, what I would guess the vast majority of the American public and would consider to be kind of boring policy proposals, a little wonky, like real-time assignment of beneficiaries into Medicare choice. It probably is not going to move the election needle in November of 2024. A lot of these like really small nitty-gritty things, they may be hard, But if you do enough of these things, there's this really interesting set of briefs that were put together by folks from various institutions on these sort of 1% things that you can do to save 1% here and there. That type of stuff is really valuable. Even 1% of the stuff we're talking about is really valuable. At the same time, like we think about what would actually move entrenched interests is we're probably going to need some personal connection to these things, some disruption in how we think about this stuff, right? Think about the last time you did open enrollment at your job. It wasn't, do you want to have this awesome healthcare insurance plan, this terrible healthcare insurance plan, or half and half, or do you want a little bit higher wages and maybe have a slightly less generous? It's just like, do you want to pay for this one or that one? Even like that's best case scenario, right? That's the best case scenario that anybody can have at their job, is to have a choice of 2 healthcare or 3 healthcare insurance programs. So what about getting us all to recognize when this happened to us, right? Think about that time that you opened up that envelope and you saw a $20,000 bill from an anesthesiologist. That is like earth shattering, right? And so to just sort of brush that aside and say, yeah, but it's hard, is true. And also I think we can do more, right? We can start at the bottom up with these sort of wonky solutions, and we can start with the top down with building some, hopefully a little bit of, interest and political will around this to build on the things that have come before, right? In the ACA and the coverage expansion and the paradigm shifts in terms of how we pay for and deliver care here in the country.
And if I could build on that with one quick point, I think this is a really important question. We get a lot of pushback from people employed in the healthcare sector, from local policymakers saying, the hospital in my area is a huge employer. When you think, particularly during a recession, about jobs that are growing and sectors, people say, we better be careful not to harm the healthcare sector. It's an engine of job growth. And I think that's exactly the wrong way to think about it. Our healthcare system is not the world's most expensive jobs program. Every dollar that we spend on people working in healthcare is the higher premiums that individuals have to pay, or the higher costs to the government of public programs. That's great if it's generating health, but if we could have the same health outcomes and employ half as many people in healthcare, that would actually be a good thing. The opportunity cost that Mac laid out, the innovative programs that Commissioner Burrell described, we could use that money to pay for jobs in those other places that were producing more benefit. So I don't think we should think about having jobs in healthcare as the goal or as a good thing in and of itself. Those jobs are only good insofar as they're producing health and well-being, more so than if those people were working in education or transportation or housing or food production or anything else that people also value.
And just to add a last point to this discussion, thinking about how do we get out of our entrenched way of doing the things, that's why I keep talking about the data, is that really putting in front of people and doing much more work to understand the impacts by producing the data that shows this, because we all know that the current healthcare spending is not sustainable. So what does the data show us? And second is, one of the approaches we've taken is to look at money that's already going into the community. So the community, so the determination of need example I gave you, that was money that was already going into the community, but we adjusted how it was spent in the community to see a better impact. So there's lots of places where there's already touch points that can be looked at in different ways. And that's kind of a way to look at existing funds and how to spend them better.
Thank you. Those are such important points that are just front and center of thinking about these, how we should just keep that vision of the things that need to be illustrated to make this conversation go in the direction we want. So a couple of questions have come in about the rural settings. Many of these issues we're discussing, possibilities, are really different when we turn to a rural setting of limited providers, of more, especially during COVID, talking about the interconnectedness of organizations. What are your thoughts about the rural context and anything different that we should keep in mind in addressing healthcare spending and waste and opportunities for social determinants investments in non-urban areas?
Well, one example of the importance of how we pay for healthcare is the huge increase in the use of telemedicine during the COVID period. We've had, video conferencing for a long time, and we just haven't used it very much. Patients weren't comfortable with it, doctors weren't comfortable with it, and we didn't reimburse for it. And so with COVID came the necessity of making sure that people had access to healthcare without going into settings where there might be spread of disease. And so we all started using telemedicine, in part enabled by reimbursement of it through public insurance programs and private insurance. That may be here to stay, and maybe one of the small silver linings of the pandemic, because rural areas in particular are often underserved by specialists, by mental health providers, by all sorts of specialty care that is just in short supply there. And urban areas, there are often dramatic shortages of primary care providers. So to the extent that we can use telemedicine to increase access, that would be a really good thing. And our payment models better align with that, or we're not going to get it.
And just one other sort of piece to add as it relates to the opportunity cost of this would be, yes, it's absolutely the fact that there are unique challenges to providing healthcare in a rural setting, but that doesn't mean that it's easy to provide social services in a rural setting, and that the opportunity cost would necessarily be like missing there, right? It's quite challenging to have to drive half hours or hours between different clients or populations that you're trying to serve. So it may be different in the calculations of what the program would cost or what the benefits might be, but sort of the same principle, I would argue, should apply. That at least that should be our starting hypothesis in this case.
Yeah, and just to add to that, when thinking about different communities, including our rural communities, it's about elevating the voice of the community. So every community has their own needs. And for example, related to COVID-19 in our rural communities, this example that was given earlier about transportation being important, it's important in a different way than, say, in a city population. So really understanding what every community has its own unique needs, and making sure we raise that community voice is really important in anything that we put forward from a policy point of view.
Thank you. That really illustrates well, especially thinking about telemedicine, about how it's about taking advantages of these opportunities and aligning incentive payment systems too. So this brings us to another set of questions that have been about competition, innovation, and related to technology in healthcare. How much can we think to market forces, competition, particularly for a way to be automatically adjusting and bringing our healthcare priorities into alignment? And on the other hand, we think about technology as one of the largest drivers of healthcare costs, and there's policy involved here too, because we have patents and we have high entry barriers. All of these are things to do with the how the sector functions. So open up to any of the panelists. What should we think about these? And thank you to the audience that's giving us these questions to think about. Some of the other workshop panels to come also will delve into these topics. But I'd love to hear your thoughts on them.
I'll just start with a personal anecdote. I know Dean Baker is going to have a lot more to say about the economics of all this, but it's actually one of the main things that got me interested in this, which is when I first went back to get my MPH, I looked at my insurance coverage, and this was prior to the ACA. Smoking cessation was not covered. And I was like, why would that possibly be? This is a school of public health, and we're not covering smoking cessation benefits. And I couldn't really ever get a straight answer, but the best answer I got was, this is like a graduate student's insurance plan. The only thing we know is that we're not going to be covering you when you get lung cancer when you're 50 or 60 or 70 years old. There is a market failure in a lot of places in our healthcare and our health insurance that I think it's probably worth us just taking some steps back and figuring out where will the market give us the system and the healthcare outcomes that we want, and where won't it? And really sort of leaning into what we collectively can and should be doing to sort of intervene where it won't.
Thank you, Inga.
That's a great anecdote for highlighting why sort of unfettered market competition is unlikely to lead to the kinds of investments in long-term health that we would like to see. And you see that sort of across different types of insurance plans, because a lot of the long-term health consequences that we all bear happen when we show up on Medicare. And so any private insurance plan that's covering you before age 65 has limited incentive to worry about your care after age 65. Now, the classic traditional economics model would say, as people, as patients, we're the ones worrying about that, and we should choose insurance plans that have the right kind of investment. But that is really asking a lot. In fact, it's asking too much, because none of us knows the medical literature the way our healthcare providers would. And we can't expect the market to function perfectly. It's inherently imperfect. There are limited numbers of insurers to choose among. There are limited numbers of providers to choose among. There are limited numbers of medications to choose among. So we have a strong interest in social insurance, meaning ensuring a floor of access and quality of care. We can't expect private markets to do the kind of redistribution that comes through social insurance, and that stems from our priorities as an electorate, as a society, about what we think is important to provide to all members of society. That's a public policy decision. That's not a private insurer's prerogative or priority. That said, I think it's really important that our public policies foster innovation and competition while managing those things that are just not going to come out of a competitive marketplace. I think we would not have seen COVID vaccines and medicines without the partnership between the government and the private sector. That kind of innovation and that speed of development really can't be done, I think, nearly as effectively by a monolithic government. Or if you look at the Medicare program, it took years and years and years, decades, before it introduced a drug benefit, because at the time that Medicare was created, drugs weren't an important component of healthcare, and the program was just slow to evolve. So we have some great examples of managed competition, like Medicare Advantage, which now, more than a third of Medicare beneficiaries choose to get their Medicare benefits from a private plan that's subsidized by the government. Most people who get Medicaid are getting Medicaid managed care through their state plans. Lots of people are choosing private policies through the health insurance exchanges, subsidized by federal subsidies based on income. So I think we have a lot of models of where that can work, and I would love to harness the best of both.
That's great to think about the importance of policy and industry and all of these market forces and policy working together. So we've covered a lot of ground, and there is a lot more we could keep going on about, but this is why we have a workshop of 2 days. I'm really excited about the panels coming up. I wanted to give the panelists an opportunity for some takeaway remarks. I'm going to go in the reverse order we had the presentation. So Commissioner Burrell, if we could start with you, and then Kate and Mac. So what are the things you would leave our audience with as last comment?
Absolutely. Thank you so much. Again, it's been incredible to hear and learn and engage in this discussion. I'm really optimistic about the future. Related to the last question, actually, and I would use this as a summation point, we have learned so much from this pandemic. And one of the things, as we think about individual responsibility for our own health and healthcare, this last year has shown us that we're all interconnected, and the decisions one or the other of us make related to our health affect all of us, literally all of us on a global level. And I hope that some of the lessons that we've learned from this pandemic, we will not lose as we go back to whatever our new normal is, but that we use them to inform these discussions we're having. So our interconnectivity among us, and how we really have to look at health as a public good and something that we all are invested in. And my health is directly connected to my neighbor's health. And if the COVID-19 pandemic hasn't shown us this, I don't know what would. And second is, as we think about this work, and this has come up earlier, and Matt discussed this as well, is thinking about our public health infrastructure and supporting that so that we can respond in a historically underfunded system to whatever pandemic or issue comes next. And then really thinking about how do we make sure as we have this dialogue and discussion that we think about equity and strengthening opportunities for all of us and using a data-driven approach to really care for all of us as a population and our health. Thank you very much.
One of the things I particularly appreciate about those remarks is the importance of bringing evidence to bear, that there are lots and lots of programs that are really well-intentioned and sound like wonderful ideas, but then don't work in practice. And the sooner you figure that out, the sooner you take those resources and put them towards something that might work a little bit better. And being really clear-eyed about that evaluation coupled with experimentation, I think, is how we get to a higher value system and better outcomes. So we need to start by being clear about what our public policy goals are, and they're competing goals, and that's nothing that data can tell you or that evidence can tell you. You have to know what you're trying to do. But then you have to be really rigorous about assessing what's achieving that goal, what incentives you need to put in place to drive towards that goal, what's working and what isn't working, and then thinking about designing public policies that are going to generate the right behavior in private actors, whether it's patients or healthcare systems or innovators, and thinking dynamically, not just about what your goals are for today, but what your long-term goals are for population health trajectories as we have an aging population, for innovation and sustainability over the long run, for the medicines of tomorrow, not just the medicines of today. That's a lot to think about, but I think that we have learned a lot in the last year, about how interconnected all of our health is, about how fast we can drive innovation when we really put our efforts together, thinking about the public side and the private side, and about the deadly cost of the unequal access, the disproportionate burden that some populations face, and how important it is to fix that patchwork system. So I hope that we get there sooner rather than later.
Thanks. And Commissioner Burrell, Dean Baker, Dr. Simon, it was really an honor to be on the panel with you all today, and I appreciate the invitation to participate. And just sort of as a final wrap up from as it relates to sort of the opportunity cost and our health dividend would be, in the US, we tend to innovate better, bigger and better, MRIs that can see more, and there's huge benefits to that, period. But there's also, implicitly, we could have innovated the other direction. MRIs for more people, cheaper MRIs. They may not be as high of quality, but we could do two okay MRIs or one exceptionally great MRI. And I think it's just important that we lean into that and sort of recognize that as a society that we do and we have implicitly or explicitly chosen to provide one exceptionally good MRI for one person rather than two pretty good MRIs for two people. That's a normative decision to an extent. And if we want to make that decision as a society, that is our right. But we do have some say, given that we're talking about public dollars here, to sort of, actively, affirmatively state that. And so just to sort of reiterate, there is that opportunity cost to how we allocate our money towards health, given, sort of how we can, the various routes there are to producing health outcomes.
Thank you. Those are just really an amazing set of comments and insights you have shared. We're just so grateful to all three of you for having taken the time to help us understand this really big issue. I also really want to be very, very grateful for all the questions from the audience that has really enriched what we can discuss here. And we are going to keep continuing this conversation through the other panels. I want to take a moment just to think of all that we've set up here as what's the problem, what's the opportunity in front of us, what are possible pathways, and to hear of evidence from initiatives that have taken place, ideas from initiatives that are in place based on the evidence that has been brought to bear, and all that we have learned during the last year. So I think I'm speaking for the audience that's been responding very favorably with appreciation. You've set us up for moving forward. We're going to take an hour's break and join back up at 2 p.m. I want to thank everybody. Thank you, Ray and Sandy, for setting all this up in advance, the staff, and we look forward to a much longer discussion on this in action. So thank you to everyone.